Hello to my medical directors. This is Nick with the STARS program. This video is part of our How to Use the Application video series, and it is specifically aimed at the role of medical director. We are going to take this opportunity just to talk through a few things that might have changed with the program. For some of my medical directors, I know we work very closely with you all the time, and this will be kind of a repeat of other information sessions you've already attended. But for some of my medical directors, I know we interface with you much less frequently, and it was an opportunity to kind of show you the direction that we are taking the application and the program as a whole in. So the first thing to talk about is the fact that there are actually two different medical director roles now. So for every STARS form that exists in the application, it has to be approved first by a medical director from from a children's hospital who is the data owner. So they verify what the STARS teams at the hospital have written. They say, yes, that's an appropriate plan, or they say, no, you need to rewrite that plan. And then they choose to approve or disapprove. And only after that medical director from the children's hospital has approved the plan will be sent to the EMS medical director, so that they can either approve the plan or defer the plan. They can say, yes, that is 100% appropriate for my EMS crews. We can do that for that child. Or they say, you know what, we don't carry that med. That's not appropriate. That's not enough information, or we need something different on that form, and return it back to the STARS team at the hospital to rewrite. There are no more plans being written in the field. All plans now come from hospital personnel. This was nothing personal against the EMS agencies. A lot of them did a great job, but it was just the way we had to structure the program so that the data owners were responsible for their information from the children's hospital. I do still occasionally get, and so just to be clear on that information, so I could read off the list to you, but I think the more important way to look at this list and to who we put in STARS is we really search for those kids who do not follow typical treatment algorithms. So, very much in emergency medicine, we're taught you see 1, 2, 3, you treat ABC, and that's meant to keep us safe and properly treat the vast majority of our patients. But we all know that there are those patient populations where if you blindly follow those recipes, you won't help your patient and you might actually hurt them. And so, if we need to deviate on airway with our trach patients or breathing with our vent patients, whether my cardiac kid typically SATs in the 70s or else, I have a hemophiliac who doesn't clot appropriately, I can have all these different issues that I need to address. I know that you are all very well trained and probably already have a lot of this knowledge, but we're really working at how can we replicate this knowledge and provide it to all the care providers who are using STARS plans to treat these special needs kids. All right, and then just to kind of reiterate every STARS plan that you see in the application where it came from. So we receive the referrals still from EMS agencies if they're encountering kids in their venues that are challenging their EMS providers, and they say, you know what, we'd really like you to take a look and see if this kid is appropriate for us. It is still meant to be a system that aids EMS first and then outline facility EDs. And then we are finding actually some uses for closer in at the tertiary facilities as well. And so those referrals come in either from the field or from within our hospital, from our discharge coordinators at our NICU and our TCU or our ED. And then where we get double checked on the plans, so we have paramedics working as the STARS program liaisons and coordinators at the hospitals, we write the plans and then we get double checked at the specialty review level, whether that's just our medical director for our programs, which is currently Dr. Laffey at Cardinal Glennon, or Dr. Siegler over at Children's, or sometimes for the really, the kids with the really crazy plans, such as, you see a propionic acidemia plan here. Sometimes we have to go, straight to the genetic specialist or the neurologist and ask them what specifically they want done for those kids. Then, as I said, once that plan gets approved at that level, we still send it out to you as EMS medical directors. And so this is your chance to, say, yes, that's appropriate for my crews or not. One thing I do like to reiterate, I never want you to feel like you have to rubber stamp plans. We do work very hard on them to try and make sure they're appropriate for EMS before we send them out. But, if you ever have questions or concerns, please, don't be afraid to fire that plan back to us, and let's settle that before we make it a live plan. We do find that these two steps, these two stages in lockstep together, are essentially allowing us to write custom-made protocols for these kids in our program. And, to me that makes sense because they deviate from typical protocols. A lot of times it's not radical things. It's things that actually make sense. For instance, just a brief example, my cardiac kids, if you take a kid with hypoplastic left heart who is never going to sat over 85%, well, a lot of us in our EMS protocols say, if less than 90%, treat with oxygen. And if we took our brand newest of paramedics that day with wet ink still on their P card and we sent them on that call, they're going to say, this kid is satting less than 90%, I must give him oxygen. And so we all know that's a bad idea. That kid can actually never sat 90% because we gave him a frog heart. And so we just simply need a set of rules that say, you know what, for this kid, if he's on, as long as he's 75% and he's not blue and he's not having difficulty breathing, he looks pretty good to go. And so sometimes it's just don't follow your regular treatment protocols, and sometimes it's, hey, we need you to do this specific thing in addition to your treatment protocols, such as administering factor to a hemophiliac or something like along those lines. We do still work hard on the live plan and doing the training with the crews, especially in the stuff that are new concepts or not well-taught concepts to EMS. I would consider education as the second pillar of what we do. We write the plans, but education is a huge component of it because they're just words on a sheet of paper until we come out and talk about some of the concepts and the treatments that need to go on in relation to those plans. So next up, we're going to do a video specific to the STARS application on how you're going to receive your email and approve or defer your plans.